Hi, we are going to talk about personality disorders, um, uh, predominantly from an overview of Lariviere's chapter in Brown, Munoz, and Stoffel. So, personality generally, not any particular disorder, is thought to be kind of a combination of environment and genes. And we'll talk about later, psychodynamic theory really rules in the area of personality disorder and our kind of thoughts as to the environmental part of that. Um, and there is a belief that there is also a genetic piece to it. Um, so generally, five factor theory of personality, or the big five, are to what extent do all of our personalities include neuroticism, which is kind of more negative effect, anxiety, hostility. Second, extroversion. How assertive, how much excitement do you see? Kind of how out there are you? Um, Third, openness to experience. So, do you like new ideas? Are you into adventure, game for whatever? Uh, Fourth is agreeableness. So, altruism, compliance, following the rules. Following the rules is probably more conscientiousness, which is about self-discipline and order. So, all of those are kind of uh, uh, factors that are kind of considered when they think about a person's personality. And then we all have characteristic adaptations, both in our interpersonal and our intra personal characteristics that develop over time based on our environment. So, personality disorders, they are considered an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the person's culture. So, you can kind of chew on, think about all of the conspiracy theories out there, and you can kind of chew on, could that be related to personality, or is that in fact a reflection of a subculture? I don't know, but it has to deviate from the expectation of that person's culture. It is pervasive and inflexible, has an onset generally in adolescence or early adulthood, tends to be very stable over time, and leads to distress or impairment. Um, Personality disorders get a bad rap in therapy disciplines. It initial back in the last several iterations of the DSM Diagnostic and Statistical Manual, they were on Axis 2, um, versus Axis 1, which is where the quote unquote major mental illnesses are. Um, and in this fifth DSM, they moved them up onto Axis 2. And I really think it is to try to get them to be taken seriously, and not just kind of discounted, because they cause an enormous amount of uh, difficulty in people's lives. Um, so, uh, diagnostic criteria state that that person should um, have a significant impact in at least two of these four enduring patterns, um, uh, that, or that they have, it is an enduring pattern, but in these four kind of areas of pattern, which are thinking, feeling, interpersonal relationships, and impulse control. So thinking, that's kind of the cognitive piece. They can have distortions in the way that they see themselves and in the world. Feelings can be really muted, as in a schizotypal, which we'll talk about in a minute, personality disorder, or extreme or vacillating between extremes. may have really extreme and persistent dysregulation is characteristics of a couple of personality disorders. They may have significant difficulty with impulse control. And really, the most persistent consequences of personality disorders are difficulties in relationship, um, largely because of their distortion of reality, extreme feeling states, and that difficulty with impulse control. So, first cluster, and we'll look at them across several clusters. First cluster is overall, you can kind of think of it as people who are pretty odd or eccentric. So paranoid personality disorder, they're going to have a pervasive distrust and suspiciousness of others, kind of be hypervigilant, um, maybe argumentative or aloof, demanding, moralistic, just really have difficulty with trust, different than paranoid schizophrenia in that a paranoid personality disorder, their paranoia is more plausible than in rather than psychotic. So it's not doesn't quite reach the level of delusional consistently anyway, although they may kind of peek into that periodically. They may have kind of brief psychotic episodes. They generally stay more tethered to reality than someone with with paranoid schizophrenia, um, which we'll talk about in a whole nother uh, video. And then the next is schizoid personality disorder. And this is, they tend to be, so when again in another PowerPoint we talk about schizophrenia, we'll talk about not negative and positive traits, and the negative traits are kind of taken away from their personality. In schizoid personality disorder, they kind of have that detachment. They're kind of flat, very socially detached, prefer to be socially isolated, may be okay at work if they don't have too many interpersonal demands, but they really aren't people. Um, so, and then last are schizotypal personality disorders. And this is that person with very magical thinking. For example, paranoid beliefs, or paranormal, excuse me, beliefs that they can read each other's thoughts or reads other people's thoughts, or that they have kind of special powers, which also happens in delusions, but this is not exactly to that extreme. They're a little more, again, tethered to reality. Um, Often will come off as kind of eccentric and flighty. Um, they have a lot of social and interpersonal difficulties, tend to be kind of uncomfortable, have limited close relationships. They're really generally perceived as weird. Similar cognitive deficits as schizophrenia around attention. So they have some difficulty around executive functions, working memory, which may be why they make those connections, but another outside thought. So that is cluster A, generally odd or eccentric. Cluster B there are 4 disorders in here. And they are antisocial personality disorder, which is a pervasive pattern of disregard for others. So they violate the rights of others with really no remorse. In childhood, most of them have been diagnosed with conduct disorder, although not everybody with conduct disorder will be diagnosed with an antisocial personality disorder. As a parent whose son was diagnosed with conduct disorder was pretty terrifying because I thought this is where we were going lockstep. Hence the picture of his book. Um, there tend to be more males who are diagnosed with antisocial personality disorder, and there is some argument that antisocial personality disorder and borderline personality disorder may be two expressions of the same thing based on how males and females are socialized in our culture. Um, so and and there are arguments that there are a lot of people that are pretty functional with antisocial personality disorders. It's not necessarily um, they may be executives of a company that really don't take care of anybody and really don't care about it. So it's not necessarily um, um, what the kind of sensational things that you hear say, but there is a pervasive pattern of disregard. In borderline personality disorder, there's a lot of instability as well as antisocial personality disorder in relationships, in self-image, in affect, impulsivity. Tend to have black and white thinking, meaning that everything is wonderful or awful. So the most dangerous thing working with people with borderline personality disorder is if they come up and tell you you are the best therapist they've ever had, because that means you know that tomorrow you're going to be the worst therapist they ever had because they just flip back and forth like that. Can't take it personally. They tend to feel chronically empty, may have recurrent gestures of health self-harm um, uh, that are problematic because you have to take those seriously. Um, but taking them seriously means giving them a whole lot of space and attention, which is doesn't help them at all. So that's kind of a conundrum. Narcissistic personality. So, narcissistic personality disorder is they tend to be more grandiose, have very intense reactions to perceived slights. They People with borderline personality disorder distort reality. People with narcissistic personality disorder, that is even more extreme. That distortion of reality. Everything has to be making them okay because they get their sense of self entirely externally. So they kind of require constant affirmation and they literally cannot tolerate less than that. Um, so your book talks about borderline personality disorder in youth. Usually that diagnosis is not given until these diagnoses are not given until adulthood, till about 18, even though they may start much earlier. Um, and some of that is, if you've been around adolescents, lots of adolescents could be diagnosed with something. So you have to kind of see, is that part of that shift with all of the hormones coming in and all of the change that happens in adolescence normally? Um, uh, in some ways, adolescence itself is almost a disorder with lots of drama and all the things that go on. Sadly, thinking about these personality disorders, um, and in particular antisocial personality disorder, there is a there is racial bias in how those diagnoses are given. Um, very it is more frequent for a person of color to be diagnosed with oppositional defiant disorder, and then that to become a diagnosis of conduct disorder, and then that could be a diagnosis, progress to a diagnosis of antisocial personality disorder. Whereas perhaps more often in Caucasian kids, that's going to be called ADHD instead of oppositional defiant disorder, and progress to bipolar and be called that instead, just based on how we misinterpret what we're seeing based on our own bias. So, borderline personality disorder versus bipolar disorder. Uh, excuse me, in borderline personality disorder, there is persistent volatility, and they're all over the place in their distortions, and sometimes to the point that it kind of looks like delusions. But it's consistent, whereas in a mood disorder, that only happens when someone is really manic. And once their mood gets stable, it goes away. So it's the course of it that kind of often may differentiate. Then the next, oh, gone backwards instead of forward. The next cluster is anxious and fearful. And these are people with avoidant personality disorder. So social inhibition, feelings of inadequacy, hypersensitivity to criticism. They may fear rejection, so may avoid social activities. And avoidant personality disorder is different than social phobias, really in intensity, is the difference. It's kind of a persistent, low level pattern of being. Dependent personality disorder, they tend to perceive themselves as powerless, become really anxious when they're expected to function with an autonomy. Can over-identify in a patient role. So you need to, that's an important thing that you will come across in many different settings. They have a deep fear of separation and a need to be cared for at its base, because they don't feel like they can take care of themselves. And then obsessive compulsive personality disorder, they have a preoccupation with orderliness, perfectionism, intolerance of mistakes. They are very controlling, but they're not distressed by their perfectionism at all. They just see it as this is the way things ought to be. Some of you may have a touch of that. I have worked with people who were extremely productive that leaned toward an obsessive compulsive personality disorder. Everything just kind of has to be done right and in its place, and they have a real difficulty with mistakes. Difference between an obsessive compulsive personality disorder and an obsessive compulsive disorder. People with obsessive compulsive disorders usually have some insight. They usually recognize that this is not working. They feel compelled to do whatever it is, that those compulsions to relieve their anxiety, but they have pretty good insight. Whereas people with obsessive compulsive personality disorder are completely happy with the way they are. The rest of the world just needs to change. And they see it as beneficial and kind of take pleasure in being perfectionists. So those are our clusters. Now let's talk about kind of etiology and comorbidity. So what causes a personality disorder? Genetic versus and biological factors. Sometimes it does run in families. Now, hard to say whether that's nature or nurture, but there is a potential heritability of traits such as emotional liability, which is lability, which is all over the place. Um, uh, and they're looking at potential gene neurotransmitter relationships. In emergent neuroimaging studies, there are physical changes in the amygdala in paranoid personality disorder, in the temporal lobe in schizotypal personality disorder, in the prefrontal cortex in borderline and antisocial personality disorders, and in the frontolimbic regions in narcissistic and obsessive compulsive personality disorders. Psychological factors, psychodynamic theories, like I said earlier, reign in our understanding of personality disorders. So, looking at the personality organization in specific disorders, so the differences in extent of primitive defense mechanisms, again, psychodynamic theory kind of rules for personality disorders. Um, they're splitting their poor sense of self or identity diffusion, their distortion of reality and impulse control. Um, there is, did it again. There is from a psychodynamic point of view, you can kind of think of it as the superego deterioration. So it might be related to antisocial personality traits. So there isn't something saying, no, you should do this. I'm just going to do what the id says. Um, and then in narcissistic personality disorder, it is thought that because they really are the most fragile of that cluster B, um, that the difficulty with attachment and disruptions probably happen much earlier in their development than someone with either um, borderline or antisocial personality disorder. There is a theory, the mentalization and attachment theory, that again, similar relationships in childhood shape our personalities. When attachment is poor, people may have a problem with emotional regulation or self-control. And then schema therapy is kind of or theory rather, is kind of a fusion of psychodynamic and cognitive behavioral theory. And that's the idea that when needs in childhood aren't met, people develop maladaptive schemas or systems of beliefs or themes to help them understand the world. And they move into adulthood with those schemas, which may have had them help them survive some pretty difficult childhoods, but they really aren't functional moving into adulthood. So comorbidities, post-traumatic stress disorder, again, there are some correlations, particularly with complex trauma and early trauma and narcissistic personality disorders. There are associations with antisocial personality disorders and borderline personality disorders as well, um, uh, with abuse. Not 100%, again. And then there are comorbidities with substance use disorders, sometimes again, because of that difficulty with dysregulation or as a trauma response. Substances are a way of coping with ADHD or limited attention again, think about some of the cognitive pieces that we've talked about, and those overlap. Eating disorders may coincide or be comorbid with personality disorders, certainly anxiety and all kinds of physical health problems. And it occurred to me, we did not talk about histrionic personality disorder. Attention, they're in cluster B still, very attention seeking, flamboyant, exaggerated emotional expressions, may have difficulty seeking relationships because they're always seeking novelty. I apologize for having dropped that off. Now we're back. So bias and stigma and uh, the impact of personality disorders. There are gender differences in diagnoses, which could reflect bias or differences in socialization. For example, we talked about males with antisocial personality disorder or narcissistic personality disorder versus women who are more often diagnosed with borderline, histrionic, or dependent personality disorders. So how much of that is kind of a fusion also of socialization? Personality disorders, again, get a bad rap, and they're often seen as really difficult people. They are difficult people to work with. Um, but these are really crippling disorders, and it's important to remember that. Your author talks about people with personality disorders are seen as people who misbehave rather than people who suffer and need help. But they are, in fact, people who suffer. Personality disorders impact all the roles in their lives. People with personality disorders often have developed patterns of behavior that help them survive early abuse or neglect. And they just don't work in adulthood, but it's all they know. So from an OA perspective, an occupational adaptation perspective, this is the adaptive response mode that they know. They are habitual patterns of behavior, which makes them really hard to shift. Personality traits across many personality disorders cause problems in all kinds of relationships, at work, really anywhere where they have to interact with other people. Parenting is a challenge if your own needs are overwhelming. And they may not have had great examples of parenting in childhood, so it's hard to suddenly do what you've never seen and don't know. So recovery, and your book kind of uses the PEO framework. Recovery is hard. It's not impossible. But it's hard. First, they have to really want to change. And usually that's because there's a role or a relationship that's really important to them. I worked with a fellow with narcissistic personality disorder who really, he was not young, and he had blown up a number of different opportunities in his life. And he found this little job that he really loved, and it really fit his understanding of himself. And he really wanted to keep that job. But as usual, his personality traits were interfering with his ability to maintain the relationships he needed to maintain to keep a work role. But he was willing because he really cared about that role. And I was with him long enough, because you have to remember, working with people with personality disorders, this is not a short-term fix. It's a long-term process. So you also have to be with them long enough. That's probably more likely to happen if you're working with them in a work role, because very frequently, wherever you see them, and you will see them all over the place, um, uh, you're not going to be with them long enough for them to make a dramatic change. Um, so this fellow, we were able to just kind of gradually, he would have a conflict with his boss, and I would just ever so slightly turn that mirror toward him and say, huh, that behavior didn't work like you expected it to. What do you think might? And we were able to, over a period of years, help him make adjustments, little tiny adjustments, until he got to the point where he could hold the job. Now, did he ever have functional relationships? I really hardly doubt it. But he was able to keep that job that was important to him. So anyway, recovery is a process. They're developing new patterns, not returning to established ones. So these are not behavior patterns that they can go back to. They're having to completely build them from scratch. So see table 22.2 in your chapter. Um, uh, Within themselves, a person with a personality disorder has to develop strategies for emotional regulation. They have to shift their ways of seeing and understanding relationships. So think cognitive behavioral strategies. DBT, which is dialectical behavioral therapy, is an effective, intensive set of strategies that is effective for people with a borderline personality disorder and some others. It includes kind of mindfulness, um, uh, learning about and developing skills around distress tolerance, skills training in many areas, skills for emotional regulation, for effective interpersonal skills. Um, uh, environmental components of DBT are 24/7 on-call crisis support, because remember those suicidal gestures, um, uh, to kind of um, do a work around those. There's a 24/7 kind of on-call crisis person. There's skills training groups that they go to a couple of times a week. They see a therapist a couple of times a week. So it's really intensive, but it has a really good evidence base. And then meaningful occupation is key. Work is a context that they may be in therapy long enough to make an impact, and particularly if it is something that is important to them. Parenthood may be. Lots of people who have had really difficult childhoods are really vested in being really good parents, and that may be. Again, it's hard work. They're learning skills that they were not given to provide more for their children. And that's what I have for you on personality disorders. I've got you some resources here. Marsha Linehan was the developer of DBT, and she was a person with borderline personality disorder. She's fascinating. Her clips tend to be very short, so you don't need a long attention span. There are a lot of them, but she is fascinating. Um, and then there are sites specific to people with borderline personality disorder. For antisocial personality disorder, there I have referenced an article for you, and then there's more on each of the personality disorders in the last link. So, thanks. Bye.